Hello everyone. Today we will be starting the first chapter of Pediatrics Simplified. What is that? History taking. What is history taking? History taking is the foundation on which the diagnosis of any clinical condition lies. A a skillful history taking requires a lot of patience and lot of experience. If you take the history of at least 50 to 100 patients, then you can be able to represent a history at least properly. So it requires practice, patience, and a lot of repetition. So I'm giving you an example after which we will start. A patient, 11-year-old male child, came. Mother complained that, sir, my child had fallen from the bed, head hit the floor. The child had convulsion, the fisting of hand, uprolling of eyes, drooling of saliva, and after that, my child is not able to speak completely. The words are somewhat stuttering, and my child is not able to stand. So we thought it might be a head injury followed by convulsion. So the diagnosis is simple head injury. Now, when my consultant came, sir told that when the child was all right, sir asked mom. So mother said, my child was all right, sir, till 9 years of age. So from 9 years of age, child suddenly started. Child was not able to remember things. Child was not able to attend the class. The attention was down. So sir said, it is a case of neuroregression. What are you telling about the head injury part? So the head injury is something that happened as a coincidence and it's biasing us from the actual history. It is a case of neuroregression. Then we physically examined the child. There was hepatomegaly. Liver was enlarged. So how come liver is enlarged in a case of head injury? So the consultant thought, might it be a Wilson's disease that is showing its neuropsychiatric manifestation? Because there is neuroregression. The child was all right till 9 years of age. So that is the beauty of history taking. Right from a head injury, we went to neuropsychiatric manifestation of Wilson's disease, and to our surprise, it came out to be Wilson's disease. So history taking is an art. Everybody says history taking is an art. We study history taking from right from second year till the end of our career. So let's start history taking. So first, we will go to what do we study in history taking. We study, I'll be writing things, and listen to my words, I'll be writing in brief. Okay. So first we study, sorry. So history taking. Right. So first thing we need to do when we take a history? We need to ask the patient about the details. Before asking the patient direct details, build a rapport. Okay. Build a rapport with the patient. Why will the patient give you history? Who are you to the patient? You are no one. You just went suddenly and asked, what is your name? What is the mother's name? What is the father's name? No one will ask you. No one will answer you. So build a rapport. How are you? Have you taken a medicine? Is the diet all right? Have you eaten in the morning? So that is called building a rapport. Understood? So first we ask the patient details. Understood? Patient details. What are there in the patient details? Patient details consists of the name. What is the significance of the name? First, documentation. Second, confidence. What confidence? Documentation. Any medical legal part of any case requires documentation. So if there is a name, it is effective for documentation. Understood? Then confidence. You call someone, hey, listen here, and you call someone, Satyam, listen here. That Satyam, listen here builds a good rapport with the patient. So now you'll ask me, sir, today the baby is of 2 days. No name is given. How will we document, or how will you call the baby? We will call him or her by the mother's name. Either we write Satyam, or we write baby of mother's name. Okay, gone name. Second, in the patient details, what we do? Age. What is the significance of age? The significance is that certain diseases are very particular in that age group. For example, rheumatic heart disease is very specific in 5 to 15 years of age. Not that we do not find a rheumatic heart disease in less than 5 years or more than 15 years, but it is usually found in that age group. Understood? So that's why age is important. ALL we usually find in less than 10 years. So in less than 10 years, if the child presents with features we think of ALL, then their age is significant. Okay. Next, gender. Same thing. Certain diseases are male predominant, certain diseases are female predominant. I'll be focusing on history taking particularly in this video. Other things, digging deep into each part, I will make separate videos on that. For example, fever, I'll make a detailed video on fever that will be in another playlist, so that it will be easy for you to focus completely on history taking in this video. Understood? So gender, so certain diseases are very specific or predominant in certain genders. Male predominant diseases hemophilia, female predominant diseases Turner syndrome. Understood? Next we come to place. So what is the significance of place? Certain diseases are very endemic in certain places. For example, the place a place which is where the sickle cell anemia, thalassemia, there are particular belts on it. In Odisha, when we go to the western belt, the cases of sickle cell anemia and thalassemia rise very sharply. So in that particular case, the place of the patient matters. Understood? Next, in place, you ask them the place of origin. Sometimes the they belong to a particular place and now are residing in this place. So the disease, they might have carried the disease from the place where they were initially living. Understood? So next we come to informant. So what is informant? Who is giving you the clinical history? Now the child cannot give you the history, right? The for effective history taking, who is the best person to give you the history? Yes, mother. If the child is old enough, let's say 10-year, 12-year child, the child can give history of his or her own. Then, but if the child is not that old, then who is the effective informant? That is mother. Then we come to reliability. Informant can be anyone: mother, father, grandfather, grandmother, anyone. Okay, but ideally mother. Then reliability. Reliability of the informant. What do you mean by reliability? How much we can rely on what the informant is saying, right? Now the child is having fever, is having cough and cold, is having hurried breathing. The reliability of the informant, that means the informant is more concerned about the child. If the Now let's compare: the auntie of the child is giving the history and the mother of the child is giving the history. Mother is more concerned, more detailed about each and every particular thing. Sir, fever started 7 days back, then cough and cold started 5 days back, then the hurried breathing started 2 days back, sir. My child was all right 7 days before 7 days. Now auntie, sir, they were telling the child was apparently all right some days back. That is not a reliable history. In that case, we have to cross check again. So reliability of the informant is also very important. Remember, sometimes when you take history from the informant, they would be saying some particular occasions. I'll be coming to it later. Now, after saying after all these, you say all these in a single line. What single line you would say it? Sir, my patient, 7-year-old male child from this place, informant being mother, who is reliable, presented with chief complaints of. Whatever I taught you in this time, in this, you will be saying in one line. Okay. Now coming to chief complaint. In chief complaint, remember two things. First thing, English. Second thing, chronology. Do not, I'm making you understand. mother is saying, sir, बच्चे को टाइफॉइड हुआ था. So you don't write typhoid since 7 days. You ask what brought you to the hospital. Simple question. What made you to bring your child to the hospital? क्या हुआ तुम बच्चे को लेके हॉस्पिटल आई? बस सिंपल क्वेश्चन. What will they say? सर बच्चे को टाइफॉइड हुआ था. The child was having typhoid. You don't write that. You write fever since 7 days. Simple in their language. Understood? So first is patient language. Then chronology. What is chronology? They'll say that, sir, there was cough and cold since 5 days. Before that, there was fever since 7 days. And due to hurried breathing, since last 2 days, we brought the child to the hospital. So that 572, right in the chronological order. What happened first? So fever, 7 days, cough and cold, 5 days, hurried breathing, 2 days. Simple, beautiful. So patient language and chronology. These are the two main things you have to observe in chief complaint, right? Now, next, history of present illness. History of present illness. So what do we do in the history of present illness? Here we explain everything. You may use patient language. Sometimes you can use the medical terms, but never use medical terms in chief complaint. Okay, right. So history of present illness. Here we start saying the history of present illness like the patient was apparently all right this days back. To start with. Understanding. We say that the patient, sir, the patient was apparently all right 7 days back. To start with, the patient developed fever, which was followed by cough and cold, which was followed by shortness of breath and hurried breathing. And we explain everything. How do we explain everything? Fever. What was the onset of fever? Whether it was acute fever or there was a low grade temperature. Whether the temperature was documented or not. Whether the fever was high grade or low grade. Whether the fever was associated with any other thing. The more you ask about it, the more you dig deep, the more precise you get into your diagnosis, right? So let's start with fever. I'll be explaining fever in detail in another video, don't worry. Now I'm focusing completely on history taking. So time, duration, mode, aggravating factor, relieving factor, associated factors. Right? Ask whatever in detail you need to ask, but maintain the chronology. So I'm saying an example, sir, fever, the child was apparently all right 7 days back. To start with, the child developed fever that was high grade, that was not documented. The fever was intermittently subsiding upon medication. The fever was associated with vomiting. The fever was associated with chills and rigor. So we explained the when did the fever arrive, how was the fever, whether it was responding to medication or not, that was a relieving factor. There was no aggravating factor, what was the associated factors. So whatever the chief complaint of the patient, whether in fever, whether in pain, whether in convulsion, whether anything it might be, we will ask in complete details. We will maintain the chronology in the history of chief complaint. Another thing we need to ask in the history of chief complaint is the negative history. Negative history. And explain everything. If you have written 3 points in the chief complaint, you have to explain all the 3 points in the history of present illness, right? So what is negative history? Negative history means what have you ruled out. The more number of negative history you write, examiner thinks that you have ruled out that many number of diseases. Let me give you an example. Fever with vomiting. What it might be? Gastritis, right? Appendicitis, pancreatitis, gone. Fever with rash, measles, hand, foot, mouth. Fever with increased urination, UTI. Simple. Fever with altered sensorium, convulsion. Fever with convulsion. What it might be? CNS infection. I mean, meningitis, encephalitis, meningoencephalitis can be anything, right? So these are the negative history. How will we ask? Was there chills and rigor? Was there vomiting? So the patient will say, no, sir, there was no vomiting. So we ruled out some diseases. The patient will say, no, sir, there was no rash. So we ruled out some diseases. So the more number of negative history you ask, the clearer, the more precise you get into your diagnosis, right? Gone. Now we come to, and you can ask leading questions here. uh, I mean, to extract the proper history, you can ask yes or no questions here, but never ask leading questions in chief complaint, right? Let them say whatever they want to say. Another thing, in admission child, how to take a history of present illness in a child who is already admitted. uh, I mean, you are examining the child on day 4 of hospitalization. So there you take the history of present illness as first. Huh. How do you ask the history of present illness? You ask the history of present illness like till when the child was completely all right. बच्चा कब पूरा सही था? They will say, sir, before 7 days my child was completely all right, playing, eating perfectly, everything was good, and suddenly these all started. So we get to know about the disease, that the disease pathology started 7 days back. So like in chief complaint, you asked what made you bring the child to the hospital. In the present illness, history of present illness, you will ask what before what time the child was completely all right. So now you are examining the child on day 4 of hospitalization. So here you take the history of present illness. uh, when was the child completely all right from home to hospital? Like I explained everything, you ask everything. Then from hospital to day 4 of hospitalization, what was the course? I'm giving you an example, you will understand. Day 4 of hospitalization. For example, the patient came with fever for last 4 days, for last 7 days say. Okay, then chest pain since last 3 days. The patient was admitted. The patient had, we had a diagnostic tap. Pus came out of the chest. It was diagnosed as empyema. So the patient, we admitted the patient 3 days back. Now you are examining the patient on day 4 of hospitalization, right? So fever, you took the history from day 7 to day 4, till the patient was admitted. Then on day 4 we inserted a chest tube, we drained out some pus, it was diagnosed as empyema, and when you are examining the child, it is on day 4, right? So in the present illness we write, said the patient was apparently all right 7 days back. To start with, the patient developed fever that was acute in onset, and everything you explained about the fever. Then it was followed by chest pain on the left side of the chest, say. That was and the child was brought to the hospital. The child was admitted at the casualty. Diagnostic tap was done, which revealed some pus in the tap, after which a chest tube was given in the mid axillary space, in the fifth intercostal space, and pus was drained out. The case was and I am examining the child on day 4 of hospitalization. Understood? So we bring the child from the home to the hospital, then from hospital to day 4 of hospitalization. Gone. Then we come to past history. History of past illness. Very important. Everything in the history taking is important. Everything. You master a single skill and work on it. History of past illness. What do we do? What do we learn in the history of past? What do we ask in the history of past illness? Ask simple four questions. History of hospitalization for similar illness in past. History of hospitalization for similar illness in the past, or history of hospitalization for any other illness in the past. Any other illness in the past. History of trauma, surgery, or blood transfusion. Understood? History of similar illness in history of hospitalization due to similar illness in the past, due to any other illness in the past, history of surgery, trauma, or blood transfusion. If yes, let's say the child is having you are examining a wheezy child. The child is having wheeze, and the mother is giving you the history that, sir, since 2 years the child has been diagnosed as bronchial asthma, as a probable asthma. We are admitting the child continuously every 3-4 months. So there the past history comes into action. Let's say the child is a case of sickle cell anemia, the or thalassemia. They are taking recurrent blood transfusions every 2 to 3 months, or every month. In thalassemia, the child is getting admitted. There the history of past illness comes into significance. Okay. And yes, if the patient is hospitalized, ask them the duration, what was the course of hospitalization. They will not remember everything. Remember, you should understand that they are not that literate to give you everything in detail. If you are getting a patient or an informant like that, you are lucky. But most of the informants, they won't be that literate to explain you everything. You have to extract from them. Some will say that बच्चा सावन के महीने में पैदा हुआ था. Now you don't know what would be the date. So we need some idea about that also. Some will say that sir, बच्चा जब दिवाली हुआ, दिवाली के बाद. So you need to remember that occasion also. So we need to open our mind. Similarly, they will not say you, sir, when the child was admitted in the last episode of hospitalization, the child had taken ceftriaxone. No, they will not tell you that. They will only tell you, sir, some injectables were given, or some tablets were given, or sir, they gave us some tablets to eat daily. You have to guess according to the disease what could have been given. You can ask for documentation later on. Was there any discharge ticket or anything like that? Understood? Okay. Now, after past illness, we come to contact history. In the contact history, I'm telling you a funny thing. In the contact history, what contact history we take? We usually take a contact history of tuberculosis, right? How do we ask it? We ask, is there anyone in your family or neighborhood who is having a chronic cough? Simple question. Is there anyone who is taking medication for TB? These two questions people can understand and relate. Never ask, is someone having TB in your neighborhood or family? Whenever it is, you can go and have an experiment. If you ask them, one of my colleagues asked, do you have TB? The patient said, yes sir, I have 2 TBs. So they will not understand what is TB. Either you ask them in the local language, like in Odia we ask बच्चे को मतलब जख्मा, that's the local language. Never ask them directly, do you have TB? Does someone in your family has TB? No, don't ask. Either chronic cough, or if it's someone taking medication for TB, they'll relate that. So contact history, what do you mean by significant contact history? According to a book says that any person, any child coming in contact with any diagnosed case of pulmonary tuberculosis within the last 2 years, is said to be a significant contact history, right?